Welcome to the Health 210 podcast. In this episode, we deep dive into understanding our breathing and common lung diseases. Our guest today is an expert in pulmonary and critical care medicine. He is the physician you want when the lungs are failing, the ICU is tense, and clarity is everything. Please welcome Dr. Amalakuhan.
Thank you very much for having me. Thank you very much.
Thank you for joining us and enlightening our community, with what you do. If you could please start off initially with understanding, your training background and all, the rigorous training you've gone through, that would be amazing.
All right. So where do I start? I trained back in the state of Pennsylvania.
Okay.
So I trained in a very large hospital and healthcare system that was part of the UPMC, or University of Pittsburgh Medical Center healthcare system, very, very much like the Methodist healthcare system.
Okay.
And I had a very robust training background, mainly birthed probably in the ICU. That's probably where I found love with intensive care medicine and pulmonary care medicine. That's what my background and subspecialty is now. But I had great mentors that inspired me. What made me fall in love with my subspecialty was my rotations in the ICU.
Uh-huh.
I had great mentors. And really, whenever patients were on the general medical floors, whenever they got very sick, they all culminated in going to the ICU.
Yeah.
My pulmonary and intensive care physicians were really the ones who took care of the patients. They got them better to some degree and got them better as much as possible and downgrade them to the general medical floor, and ultimately got them home. And I was inspired even back then, and ultimately, as a result of their mentorship, I obviously chose a field in pulmonary critical care, and here I am. And
Yeah.
really,
So you saw that, the utility and the importance of care in the ICU and how that could turn people's progression around and, start making them feel healthy again. Right?
Exactly.
Perfect.
Exactly.
So critical care medicine or pulmonary medicine is a very dynamic field, right? There's the ICU setting and there's also the clinic setting. What attracts you more? Do you gravitate more towards a fast-paced ICU, or do you also like the clinic? How do you balance those?
A little bit of both. So what drew me to pulmonary and critical care medicine was the mix of both, because I knew as my life progressed and I got older, I would have to change paces very frequently.
Yeah.
For example, in my younger years, I knew I would love the pace of the ICU. I would love to be doing procedures. I do invasive procedures. I do bronchoscopies. I do endobronchial ultrasound, needle-guided TBNA lymph node biopsies. I do central lines, arterial lines, and right heart catheterizations, and so on and so forth. But I know that in the later stages of my life, I may not be able to keep up that pace that my patients may expect. So that's why I know clinic may take a greater percentage of my practice at that point.
Yeah.
So I love being known as a pulmonologist. That's probably my identity.
I see.
And being an intensivist and a critical care physician really gives me, feeds my passion as well. So it's a little bit of both. For me, my practice is probably 70% critical care and 30% pulmonary, but I know as my life goes by, it'll probably transition to a little bit more.
Balance will change, right?
Yeah.
And there are also like two different spectrums, right? In the clinic, you see the patient may have disease but is relatively stable and able to come to the clinic, whereas the other spectrum is ICU. These people are on breathing machines and critically ill and needing a lot of life support, right?
Exactly.
What common diseases do you see in both settings? What are the common conditions that you see people that end up having to go to the ICU, and then what common conditions are you seeing in the clinic that you routinely manage?
Yeah, no, good question. So in the ICU, we see patients with septic shock, which is infections that become so severe that the blood vessels dilate. We see common conditions that you see on the general medical floor in the clinic, for example, asthma that gets so severe, or COPD flares that become so severe that their respiratory function declines and they go on the ventilator. You see urinary tract infections that get so severe that it spreads to the blood and they become bacteremic, and then their blood pressure drops and they're on a lot of medications that are only present that they can be instituted in the ICU. Just those types of things. And also surgical procedures. I also didn't mention that apart from doing a fellowship after general medicine, I did a fellowship in cardiac surgical critical care at Johns Hopkins University. And the reason I did that was to ensure that I had a very broad spectrum of experience in all advanced cardiac pathologies before I did pulmonary critical care. So I also specialize in cardiac surgery outcomes and the care of the postoperative cardiac patient after surgery. So long story short, we also take care of those types of patients after surgery in the ICU. So those are the patients in the ICU. In the clinic, we take care of patients with asthma, COPD, pulmonary fibrosis. We take care of patients with pneumonia, various infections, bronchiectasis, COVID pneumonia and the sequelae after that type of infection, and various other things like influenza that impact the lung that cause long-standing consequences such as asthma and reactive airways. And there's the full gamut of syndromes that happen after all these infections that we end up dealing with, and nodules, lung cancers, and everything else from autoimmune conditions and vasculitides and pulmonary hypertension and
so a pretty broad scope of all lung disease, right? So this is where the primary care angle ties in. You mentioned COVID and influenza. So we sometimes do see a lot of our patients who have gone through these infections just can't get better, and they usually present with complaints like they still are short of breath or just can't function at that same level. At what point do you think a patient who is having those issues warrants an evaluation by a pulmonary care specialist like you? What are some of the signs that should trigger that?
Oh, that's a very good question, because being a primary care physician, I think that's an insightful question, because there's two ways you can approach it, right? There's a fork in the road. You either refer early or you refer at the point where it's definitely needed, right? When they're very, very sick. It's you refer to a consultant to put out the fire when they're really sick and they can't breathe, and emergencies end up happening. Or you refer early when we could put them on maintenance inhalers and various other things where we can kind of institute management and prevent them from, for lack of a better word, falling off a cliff. So ideally what we would like as a specialist and a consultant in the pulmonary field would be to refer early, right? And we can convert complexity into clarity and create dialogue and really get them better early so their conditions don't kind of progress.
Advance, right? Yeah, absolutely. And that could also, and that's how you could cultivate an environment of like co-management, right? You can get the pulmonary input early, institute those, latest treatment methodologies and what you would use to prevent progression. And then the primary care and the specialist can kind of work together to manage the patient better, right?
Exactly.
Absolutely. Amazing. You were recently also appointed as the new program director of the internal medicine residency program here at the Methodist Hospital in San Antonio. What inspired you to take that role, and what goals and challenges do you see in the near future coming up?
Yeah, I was very honored to take that position. Methodist Healthcare and Methodist Hospital. So Methodist Hospital is now the largest hospital in Texas, surprisingly, because Methodist Hospital doesn't get enough credit because it's not, we don't brand it nationally as well as some of the other hospitals, but it's now the largest hospital across so many metrics in Texas. Methodist Healthcare is also the largest healthcare system, not only in San Antonio, but it's quickly becoming one of the largest healthcare systems, not only in Texas, but also in the country. So it's a huge honor to become the program director. During that change of leadership that happened around May when I took on the position, I've always loved mentorship, growing people, growing students, growing residents. I was always involved in various other capacities before I took on that role. But I had a specific vision for the program, and I knew that we weren't reaching its full potential being such an amazing hospital, such an amazing healthcare institution. And that's why I really took on that role and that challenge, I would say.
Perfect.
Yeah.
And then have you been involved with like teaching and residence in the past? And how do you see or approach GME or, graduate medical education? What vision do you have to take this program, further, and what changes do you plan to make?
So in the past, I've been the clerkship director for SAMC, also known as BAMC, the military hospital here in town. So I've been the clerkship director for their ER residents who've been rotating through our ICUs.
I see.
And have got such gratification from training them because a lot of them, they come to our ICUs to get clinical training, but also procedures. And what I love about the military culture here in the United States is they're so respectful. Their military culture, they're just great human beings.
Yeah.
And the service that we provide them is to give them great training so that they can be deployed and serve our country. I've been voted I think a year or two the clerkship director of the year for their program. And what that provided me was an indication that there is a way that we can, in the community, provide great service to these academic institutions and provide great feedback not only to the military training, but also to any training institution across the country.
Yeah.
And so when we create this GME and graduate training program here at Methodist Hospital, it did occur to me that we can create something very special here as well, organically. And that's when I started creating a vision of what we could create here. I'll give you a story. So, our program, we've now been in existence. This is our second year in existence now. And you know very well, Faraz, because you're one of our core faculty members and a valuable portion of our team, and I lean on you for so many different things. This is our second year in existence. This is the first year that I'm becoming the program director, but we recently hosted our white coat ceremony. And before we started, when I took over in May, I quickly had to really get to know our incoming class, which we recruited.
You reached out to their families and loved ones to kind of know them better. Tell us a little bit about that. What prompted you to do that, and what did you learn from that?
Yeah. So when I took over the program director role, I knew I had to get to know the incoming class extremely well. I needed to connect with them because I needed to figure out what they needed in order to both inspire them, in order to not only to inspire them, but also to figure out what they needed to be successful.
Yeah.
So I called each one of them before they arrived. I got on the phone probably a month or so before they started, before the white coat ceremony, called each one of the residents up, and I asked them a handful of questions. I asked them, hey, what could we do for you, not only as a program director and as a faculty, but what could we do as a hospital, a healthcare system? I asked them, where do you see yourself in 5 years? What are your hopes? What are your dreams? Who are your role models as well, right? Because it gives me insight into who they are, who do they hold in high regard. A lot of them told me that their role model was their mother or their father. Yeah. And I got some very interesting answers, right? And if I thought some of their answers were not as, there wasn't a lot of depth to it, I would also make note of it because I knew those were the people I need to develop a little bit more, right? Yeah. And then after all those questions, I would write them all down. I have them actually on my phone because I would refer to them, right? And then I asked to speak to one of their family members. I wanted them to appoint a spokesperson, who was their mother, their father, a spouse, a grandmother, a grandfather, and they were actually very surprised. And the reason I did this was because when I finished my fellowship when I was at Johns Hopkins, my program director then, at the end of it, called my mother and father. And I remember him calling my mother. He didn't tell me he did this. And he spoke to them. And he said certain things to them and said such nice things to them about me and the way I performed and about me as a person, but also asked them such in-depth questions. And he was a Harvard interviewer. So you can reflect on how we thought, how we processed, and how we saw the future and how we developed people, and the type of mentorship I had at that fellowship, that my parents were in tears by the end of that conversation, and my parents still speak about it to this day. Right. So then I remember that, and I never thought that I would be in a position
to do that,
to change people's lives in that regard. So I took it a step further. Why don't I do this at the beginning of their journey? In the same way that coaches speak to and connect with their players and their families when they're recruiting. And for example, college coaches do the same thing.
Yeah, talk
right?
to families, get to know them. Yeah.
Exactly. So I did the same thing, and I spoke to their families. I spoke to their mothers and their fathers. And I remember speaking to one resident's incoming resident's mother, and she was a single mother, raised 8 children. This resident was one of 8 children, and I believe she was the youngest. And very tough upbringing. They were, for lack of a better word, they were of a lower socioeconomic status in that community. They were poor, tough upbringing, and she was in tears by the end of that conversation. And I got very emotional. And I asked her, what could we do for you to make your life a little bit better? And what could we do to support her? And she simply said, just encourage her, compliment her. And I had to read between the lines. So I made note of that, right? So it colors the way I approach all these residents, in the way I mentor them, the way I approach them at morning report, the way I approach them when I'm mentoring them, when I'm giving them lectures, when I'm doing simulation. Because every resident and every student and every learner learns in a different way.
Different way, yeah.
Yeah.
So it's a very unique approach, right? We don't see this in education generally, or definitely graduate medical education. We are like very typical, following certain guidelines and very stereotypical. And it's a very impactful thing to do, right? All these people who join the program, there's a whole story. Everyone has a different story. They've gone through tough times. There's a whole family that's working in the background to bring this individual up to this point. And I think the parents and the families kind of get a sense of accomplishment. That they've reached a certain point where this individual has gained a certain a position, and they're in a position to even go further and lead and educate and heal the community. So it is a very different approach, and I think a very unique, very insightful approach. And I'm sure that changes your relationship with the residents, right? It's not a typical teacher-student or a mentor-mentee relationship. You're almost kind of like a family member.
Yeah.
How does that help you? When you have to kind of give them feedback, or correct them, or still be someone who has to teach them how to do things.
Yeah, I think it helps, because I think a lot of them need, in many ways, a father figure.
Yeah.
Because a lot of them, you'd be surprised. So I needed to understand their family structure as well before they arrived. You'd be surprised how many come from single mother families.
Interesting.
They don't have fathers. Many of them. Some come from dual parent households. I did find those types of residents that we did recruit, but many do require or need father figures. That's what I sensed from their mothers, to be honest, right? And I think they do need somebody to be lenient, but also to be strong,
yeah.
right? But also they need somebody to guide them, because if they come to a mentorship environment and they're simply just walking that path alone, they're just not going to know what the destination is.
Yeah.
We need to show them the concept, the structure, and also show them the ladder.
Yep.
And if they don't know where the ladder is and where it's going, they're not going to go anywhere.
Yeah,
right?
true.
And I wanted to create the structure and show them where the ladder is and show them where that destination could be and inspire them. And that's what I want to give this incoming first year class.
Interesting, very interesting. So moving on to the next question, or at least from this, where do you see the GME landscape? Specific to San Antonio, we've seen a few recently new programs come into town. There is old UT is a big institution. They have a vast option of residencies and fellowships. In the Methodist or HCS system, do you see more residencies coming in, or expansion of the program, or fellowship programs in the future? How do you envision it, or what's your take on that?
Yeah, the goal is by 2030 for Methodist healthcare system as a whole to be the largest contributor for GME, graduate medical education as a whole, across all residencies, to be the largest in that sphere in San Antonio as a whole.
Okay, wow. Great.
Taking into account general surgery, internal medicine, obstetrician gynecology, anesthesiology, ER, because we're building all these residencies, right? Obviously, the benefit of our internal medicine program, we have an unlimited number of residency spots that we can build to, just because of the unique way that we started our residency program. So we can go to 12, 15, 17, 20. We can continuously increase just because we are the largest hospital in Texas.
We have the bandwidth.
Exactly. We have the bandwidth. We have 10 to 11 hospitals within our healthcare system. We can continuously expand. So that's where we are from a internal medicine perspective. We can continuously increase those numbers. And obviously, we already have a coexisting general surgery residency. We're about to start a obstetrician gynecology residency. We're going to very soon create multiple other residencies from ER to anesthesiology to everything else. And that's not to mention all the fellowships that we're going to create, subspecialties within internal medicine, subspecialties within general surgery. So very quickly, we're going to create a cardiology fellowship, some pulmonary critical care, and also GI as well very soon. So a lot of things are going to be created. There's also a whole gamut of of non-ACGME accredited fellowships that, for example, neurocritical care is currently non-ACGME accredited across the country, but they formalize it where there's a board certification, but it's non-ACGME accredited. We're going to form that very soon. We're creating a cardiac surgery critical care fellowship as well within our CCU as well that I'm going to be a part of with a couple of other cardiology representatives as well, headed by Dr. Triana's team within the cardiology sphere. There's so many different things.
So a lot of interesting things happening, and a lot of growth ahead. So it seems like the San Antonio Medical Center is going to become an even larger hub for medical education and advancements in like resident and physician training. Correct?
Exactly.
Perfect. Yeah.
And you may ask, and you're probably going to ask, why do this? But because the San Antonio community keeps growing, and we need more physicians with robust training to serve this community, and that's the why behind it.
Yeah, amazing. And so this is really great news for San Antonio specifically, but South Texas and all the regions that we serve as as a major medical hub. That there's a lot of growth coming in the future. Now I know, apart from being an amazing clinician and very enthusiastic educationist, you're also an avid researcher. What's currently active projects that you're working on, and what's your interest in research?
I'm doing a lot, and I'm scaling up. I took a break from academic research because I became a very busy clinician within my group. But I've done quite a bit over a very short period of time, and I'm scaling up very quickly. Within our graduate medical education program, we created a research department that's at least 20 physicians large at the moment. Right now, we just submitted a textbook chapter for publication in cardiac surgical critical care that we're revising and resending for that publication. We've submitted multiple case reports. I'm a primary investigator on a prospective study in acute kidney injury and biomarkers within the intensive care unit, using a specific type of filter that I'm partnering with some of my other colleagues within my group, and also some of other faculty members. We're working on a handful of other retrospective studies in the area of in the intensive care unit in cardiac surgical critical care and quality improvement. I'm working on multiple QI projects as well. A couple of other endocrinology projects, a couple of other retrospective studies as well. So all in all, at least about 5 to 10 ongoing projects at the moment. We're trying to scale that up. So when you take into account all the other things that I'm probably secondary and tertiary involvements with, it's quite a bit. Really what I'm trying to do is grow our other faculty members and what they're doing. We've created research curriculums to grow everyone from our residents to our faculty members. So everyone is really scaling in everything that we're doing. We have a couple of we probably have about 3 key people in our division that are really focused almost 60% on their practice on research, and they're really developing to the point where we are doing as much as anyone else in the country.
Perfect.
Really.
Amazing. So this brings me to another topic. So you're doing all this clinical work, all this GME related education, the program directorship, that takes a lot, and then the research as well. You seem in great shape, so I'm pretty sure you're taking care of yourself as well. But how do you manage all this? Me being focused on wellness, being your wellness director of the program, it's very insightful for young physicians to learn how to balance all this. With not compromising their career, making sure they reach their goals with education and research, but live a balanced life. How do you handle it?
That's always an ongoing struggle, but I think it's about good choices. So, I eat small portions. I limit. I don't eat junk food, and it's a catch-all term. I limit soda intake. I limit sugars. There's a book called Lifespan that everyone should read. But if you limit sugars, any sugars, right? That's probably probably my secret, right? I avoid starches as much as possible. I avoid desserts as much as possible. I'll probably eat a dessert probably once every couple of weeks.
Couple of weeks. Okay.
Couple of weeks.
So it's good to put that in perspective. As much as possible is different for everyone, right?
Exactly. You avoid starches, high protein, avoid junk food, avoid sodas as much as possible. Diet Coke here and there is fine. In terms of, and that's really what my diet looks like.
Okay.
And controlling portions. In terms of exercise, I keep it simple. I have 2 kids. I have a 4-year-old and a 2-year-old. So I used to work out much more before I had 2 kids. Now I keep it to probably about 15 minutes a day, sometimes even less. And that consists of push-ups, pull-ups. I have a master closet. And in my master closet, I have a push-up bar that I put on the ground, and I'm able to do maybe about 50 push-ups every day. I have a pull-up bar in my master closet that's attached to the wall, and I'm able to do maybe about 30 pull-ups in different angles that I do. And I have a squat rack in my garage that I do maybe 3 times a week, and that's pretty much it. I don't go to a gym that I subscribe to anymore. I did that before I had kids. So with this busy lifestyle, 10, 15 minutes a day, choose what you put into your body, manage what your output looks like. That's how I keep
it. So if you're consistent, even those 15 minutes take you a long way, right?
Exactly.
So great.
Exactly. And also things that will hurt you, kind of keep everything in moderation, even alcohol, even if I go out to a social event, I'll limit it to maybe 1 glass, all these things. I don't drink heavily, maybe just 1 glass, maybe once a week. Everything is in moderation, I would say.
Amazing, yeah. Very interesting stuff, very important, for all our young physicians to learn as they progress in training to how to balance that. You mentioned an important thing, your 2 daughters, right? So family life is another aspect of wellness and very important part of us. How has that impacted, your work, and how do you balance that? Because obviously part of you, a great part of you wants to spend as much time as possible with the girls, right? How do you balance that?
Ooh, so that's it's an amazing question. I love my family. Our 2-year-old and our 4-year-old have so much energy. So we have a lot of help at home. So we have 2 full-time nannies that kind of come at 6:30 in the morning, allow us to get ready. So whenever my wife and I were chairing meetings and we have to lead stuff in the morning, allow us to leave. And then when we get home, we usually get home depending on the week. Sometimes I'll get home at 7 on my ICU days, but the other days I get home at 5 p.m. So when I get home at 5, I'll play with the kids. I love wrestling with the kids, and they love getting physical and jumping on me, and I'll spin them around, and we'll play, and then we give them a bath. So I try to do so at least 2 weeks out of the month. I'll get home by 5 o'clock, except on days that I have evening meetings, and then we'll give them a bath together. We'll put them to bed. We usually split our time. My wife will put one child to bed. I'll put the other one to bed, and then every couple of days we'll switch. I'll put the 2-year-old, and my wife will put the 4-year-old to bed, or vice versa. So we kind of split the duties in that regard. And then on the weekends, it's really nice. We'll spend a lot of time together. So we do those things. We read to them. Okay. We spend a lot of time in those regards when we can.
We're making sure keeping the balance, the family, the work-life balance intact, right?
Exactly.
Okay, cool. So Dr. Amalakuhan, as a lung specialist, what are some things that you want people to really know for their lung health?
Probably the most important thing is what we've seen over the last 5 years is that the incidence of asthma has significantly increased. What people don't realize is the upper respiratory infections that people are accumulating has significantly increased in severity over the last probably 5 years. Not only during the COVID pandemic, but even the post-COVID pandemic, a lot of these viruses have mutated, evolved, and they've hit patients all across the board much more significantly. They've impacted patients' immune systems much more significantly. So patients are having more symptoms of shortness of breath, dyspnea. They don't understand why they're feeling this way.
Yeah.
So they're not seeking help, and they're kind of just managing these symptoms at home. So what I would recommend is asking questions to their primary care physicians and not ignoring them.
Yeah.
And even if they're young and healthy, but they're not able to run 2 miles anymore, but they're able to run only 1 mile, they're working a little bit harder at the gym, or if they're a little bit older and they're feeling shorter breath, they used to smoke, but they quit 10 years ago. But to at least ask these questions, do pulmonary function tests, do spirometry, and at least seek help and ask questions.
When they see like their lung functions going down and they get winded sooner, it shouldn't be ignored, right? It should be a reason for concern to seek help and get that investigated.
Exactly. Because I'm seeing so many patients with moderate to severe asthma now in patients that didn't have any history of asthma and who didn't have any classical risk factors.
Do you think it's more related to the environmental exposures, or as you mentioned, like the mutation in these viruses? Like we saw COVID go from this really severe fatal infection to now it's going to become this like a common cold kind of virus that's coming up in blips and flares. Do you think it's all related to these infections and how our immune system reacts to them?
I think the theory is that there's some interaction between the environment and the host that we don't fully understand. I think the immune system has changed significantly with these infections and all the other things that we're putting into our body that we don't fully understand, right? And now things are changing. Airway, there's more inflammation in our bodies. People are getting older post-COVID pandemic, and now they're coming with reactive airways. And these are patients that may have had some predisposition to asthma, but without this COVID environment, they would never have had any sort of symptoms at all, right? Now.
So apart from like using like inhalers or what we call like bronchodilators that help open up the airway, in your practice or research, have you seen like any medications or promising treatments or supplements that these patients can use to mitigate these effects, or is it just inhalers?
It's mainly so if it's inflammation in the body, and anything that decreases inflammation in the body may theoretically help. We're going into a realm where I'm going to be recommending things that are not bred in classical evidence. If we look at a continuum of inflammation that results in constriction of the airway, the inhalers are going to be at the end of the continuum. They're going to be dilating the airway. If we think of this as all asthma and reactive airways and it's inflammation, there's a whole host of injections now that are immune medications, things like Nucala, Dupixent, and all these other things that we're seeing that we're prescribing for asthmatics that are wiping away this inflammatory pathways that are interleukin 2 inhibitors, interleukin 5 inhibitors that we're injecting once every 2 weeks, every 4 weeks, that are taking away this pathway right here before it gets here, and these patients are not using their inhalers as much. Right? So we're using that. But there's also, if we're not looking at evidence as much, but we're looking theoretically, it's your type of diet, which decreases your inflammation. And then you do some type of, all these types of genetic testing. You could figure out what type of foods cause the greatest inflammation in your body. There's a lot of data in that area too. So you can check those things out.
Inflammation being the key, right? I mean, so whatever can bring the inflammation levels down, obesity being part of it, so the controlling your weight, diet, everything, it's a multifactorial approach.
Exactly.
Perfect. All right.
Spot on.
Now to the important topic of smoking, right? We have a lung specialist in the house. We have to discuss smoking. Smoking and vaping. So why don't we tackle these together? What is your recommendation in terms of lung cancer screening? Let's say, I know there are certain guidelines that we follow in the primary care world as to someone who's smoked should get CT scans for lung cancer screening. From your perspective, what's a good way to screen for lung cancer?
You should, when anyone comes into the clinic with any sort of history of smoking, you should definitely, to any of the primary care physicians listening, you should definitely perk up your ears to considering a CAT scan. The data sometimes varies depending on the guidelines, but anytime you have 10 pack years or 20 pack years, you should start to consider doing a screening CAT scan. In my clinic, as soon as you get 20 pack years of smoking history, I start to do a screening CAT scan on any of these patients. That's when you should do it, because you find a nodule, you should identify it early and consider biopsying it very early.
And how frequently should these patients get a CT scan? Is it once a year? If it's negative, do they continue every year? And how long do you do them typically?
Yeah, typically if they don't have a nodule at all, I typically won't repeat it at all.
Okay.
Especially if they don't have any ongoing risk factors, because a lot of the time they would have quit already.
Yeah.
If they haven't, then I typically won't, unless there's another reason to get
another one.
Yeah.
Okay, perfect. Now the important topic of vaping, right? Like in current times, vaping has become very popular, especially in our younger generation, and they almost kind of think of it as non-harmful smoking, like an alternative to smoking, which is not as harmful. But we see conditions like, the famous popcorn lung and, lung damage from vapes. What have you seen in your practice, and what part of what component of the vaping product do you think is actually harmful?
Yeah, so vaping over the last 5 years has been a significant problem. We saw it mainly in people in the teenage years, in the early 20s, even in the early 30s. And then we saw also a large group of people who are using it as a alternative to smoking.
Yeah.
And then we saw complications. We saw pneumothoraces, we saw heat-induced lung injuries, we saw lung contusions, we saw pneumonias, we saw all sorts of different things that were associated with whatever was in these vaping pens. And then we saw them being admitted to the hospital. We were putting chest tubes in them, putting them on antibiotics, steroids, and all sorts of different things. And now the incidence has slowly plateaued.
Okay.
But now we're still trying to educate the public about the dangers of it. But we're still seeing it. It's somewhat tapering now, but we're still ensuring that it's not going to spike now that we've somewhat educated the public on the dangers of it.
Okay. So no amount of smoking, no amount of vaping can ever be good for you.
Never. Perfect. Anytime you put any foreign substance in the body, especially the lung, can be helpful. The lung is probably the most dangerous organ because it's the only organ that's constantly open to the air.
Yeah.
Right? It's not the heart, it's not the kidney, it's not the liver, because those are closed circuits.
Yeah.
You can only imagine that the lung, you open your mouth, it's open to the air.
Yeah.
So as soon as you put something in your mouth, it's open to it. Any sort of smoke, from vaping to cigarette smoking, it's always going to be very harmful.
Yeah. All right. Perfect. Cool. So, Dr. Amalakuhan, where can people find you if they want a great lung doctor to see? Where do you practice? And if you can tell our audience a little bit about that.
Yeah. So I work for a very large pulmonary and critical care group called Texas IPS. So you can find us at www.texasips.com. The phone number is 210-690-7400. So you can give us a call, go to that website. You can find all our doctors there and our staff there, but we'd love to see you. Just contact us there.
And you guys take care of pretty much the whole spectrum of lung issues, right? Any asthma, COPD, lung nodules, pretty much everything. So one of the most comprehensive groups in town that take care of pretty much the whole spectrum of pulmonary issues.
Correct. Exactly. We go from probably the most stable patients, and we love to see those stable patients because that's when we can intervene early, all the way to the sickest patients that come to us with oxygen. We diagnose lung cancer. We do laser debulking for these cancers. We do rigid bronchoscopies, do invasive lung cancer therapies, all the way down just to the basics, to inhalers, to antifibrotic therapies, to pulmonary hypertensive therapies. So we do the full gamut.
So a complete comprehensive one-stop shop for all lung issues.
Everything.
Perfect. All right. Yeah. Thanks once again for joining us and giving us your time.
Appreciate it. Thank you for having me.